This conference will now be recorded.
Good morning. I'm Dr. Joshna from Department of Radiodiagnosis. Today I'm here to discuss a few points regarding the Silhouette sign and its applications. And now coming into the presentation, the Silhouette sign is based on the premise that an intrathoracic radiopacity, if it is in anatomic contact with the border of the heart or aorta, will obscure that border. In a radiograph, we will be seeing the heart, ascending aorta, descending aorta, and all these will be in, they are more radio opaque than the adjacent lung, which is radiolucent. So this demarcation is present between the lung fields and the heart because of the difference in the densities. And based on these borders, we will be ruling out some of the pathologies in the segments of the lung. The Silhouette sign is the loss of the interface by adjacent disease and permits localization of the lesion on a film by studying the diaphragm, cardiac, and aortic outlines. These structures are normally seen because the adjacent lung is aerated and the difference in radiodensity is demonstrated. When air in the alveolar spaces is replaced by fluid or soft tissues, there is no longer a difference in radiodensity between the part of the lung and the adjacent structures. Normally, the lung is radiolucent. If there is any pathology in the lung, like if the alveolar tissue is replaced by fluid or any soft tissues, the lung is no longer radiolucent and it will be radio opaque. Therefore, the silhouette is lost between the lung and the adjacent borders of the aorta or the heart. Conversely, if the border is retained and the abnormality is superimposed, the lesion must be lying either anterior or posterior. For example, if the lesion is in the anterior, or it is not. If it is not in the if it is not adjacent to the borders, or if the lesion is, we will be seeing the radiographs afterwards regarding this issue. If the lesion is anterior or posterior to the heart, means if it is overlapping the heart, it means that lesion is either anterior to the heart or posterior to the heart. If it is obscuring the border, means the silhouette is lost and the lesion is adjacent to it. In 8 to 10% of people, a short segment of the heart border is obliterated by fat pad or pulmonary vessels. This means there is some fat adjacent to the heart. A pericardiac fat and all will be there, and some pulmonary vessels are there. These will be appearing radio opaque in some 8 to 10% of people, even in the absence of the pathology in the lung. The basic tenet of this method of localization may be restated as follows. The intrathoracic lesion touching a border of the heart, aorta, or diaphragm will obliterate that border on the X-ray. An intrathoracic lesion not in anatomically continuous with a border of one of these structures will not obliterate that border. The term silhouette sign is applied to indicate the loss of lesion, loss of the silhouette of any of these borders by adjacent disease. And now coming to the differential radiographic densities, the explanation of silhouette sign rests on the fact that the delineation of any Rontgen shadow depends on differences in radiograph density. Each tissue component has its own density, but is not possible to differentiate all of them in a radiograph. We will be differentiating some of the densities. The following densities can be seen. Like in this radiograph, we will be seeing like air. This is the air. The appearance of lungs is how air density looks. This is the air density, and these are the clavicles, and this is the bone density, and this is the heart. This is a soft tissue density. Heart, diaphragm, and abdominal soft tissues and chest wall muscles. These are the uh, soft tissue densities, and overlying this soft tissue density mean this is the muscle layer, and this is the fat. This is the fat densities. Fat density. This fat density is between the muscle and air densities. This density will be in between these two densities. Fat density will be there. And now coming to the borders, borders are seen on normal chest radiograph. Why? Whenever there are two tissue interfaces, means this is the soft tissue interface and this is the air. Whenever there are two tissue of different radiographic density that lie immediately adjacent to each other, then at the interface between them we will see a sharp margin. We will see a sharp margin. This is the silhouette. Silhouette is preserved. A clavicle is of bone density. Surrounding tissues are of water or fat density. So we were able to see sharp borders of clavicle. Here we can see the sharp borders of the clavicle because of the difference in densities. And one more example is right and left heart borders are clearly seen because heart is of water or soft tissue density, and immediately adjacent to heart in the right pericardiac area is the right middle lobe of lung. This is the air density. This is the right middle lobe, and this is of air density, and this is the right heart border, and the silhouette is preserved. And now coming to a brief review of the segments of the lung. A right lung has three lobes: upper lobe, middle lobe, and lower lobe. And this is the in the upper lobe there are further three segments, that is apical, anterior, and posterior segments. This is the anterior, apical, and posterior, and middle lobe contains medial segment and lateral segment, and lower lobe we can't appreciate in the PA or AP view because it lies posteriorly, and any lesion in this lower lobe will not be obscuring the border. It will be lying either anterior or posterior to the heart. And coming to the left lobe, there are only two lobes, and the upper lobe contains the apico-posterior segment. Here in the right lobe, we will be having posterior segment and superior segment separately. And while coming to the left side, these two are fused, and it will be appearing as apico-posterior segment and the anterior segment. A lingular segment, it has this is not considered as a middle lobe. And next, this is the lower lobe. And now coming to the applications, a shadow that causes obliteration of part or all of a heart border is anterior in location and lies in the middle lobe, lingula, anterior segment of the upper lobe, anterior mediastinum, anterior portion of the pleural cavity. And here in this chest radiographs, we can see the normal chest radiograph with in the red line indicating the silhouette of the right heart border and the right middle lobe. This is the right middle lobe, right heart border, and the same red line delineating where the silhouette should be preserved. Here the silhouette is lost because of the pathology in the right middle lobe. Here we can see without the red line the right middle lobe pathology. Consolidation in the right middle lobe. Chest radiograph of a 10-year female patient with fever and cough demonstrates loss of left heart border consistent with the left lingular consolidation. And a radiopacity that overlaps but does not obliterate the heart border is in posterior in location. Here we can see the silhouette is preserved. The border is, we can see the border clearly, but there is some pathology which is not obscuring. But so this lesion is either anterior or posterior to the here the does not obliterate the heart border, is posterior in location and lies in the lower lobe, the posterior mediastinum or the posterior portion of the pleural cavity. And a lesion that obliterates the right border of the ascending aorta. Here the ascending aorta, which is obliterating the border of ascending aorta, is located anteriorly. Here there is some difference between the ascending aorta and aortic knob. This ascending aorta is anterior in location, whereas aortic knob is posterior in location. Therefore, if there is any obliteration of the border of the ascending aorta, that means the lesion is anterior. When compared to the lesion which is obliterating the border of the aortic knob, which is in posterior in location. See, a lesion that obliterates the right border of the ascending aorta, Silhouette sign, is located anteriorly and is situated in the anterior segment of the right upper lobe. Anterior segment of the right upper lobe and the right middle lobe and the anterior mediastinum or anterior portion of the right pleural cavity. Mostly the ascending aorta is anterior, therefore any pathology anteriorly to the lung or anterior mediastinum will obscure the ascending aorta. And a shadow that overlies but does not obliterate the right border of the ascending aorta lies posteriorly and is located in the superior segment of the right lower lobe, the posterior segment of the right upper lobe, the posterior mediastinum, or the posterior portion of the pleural cavity. See, in this we can see this is not obliterated. The ascending aorta is not obliterated, therefore the lesion may be present in the right middle lobe, or the upper segment of the right upper lobe, and all, and posteriorly in the posterior mediastinum or in the posterior pleural cavity. And now, and radio opacity that obliterates the, we have completed the right side. Now coming to the left side, and radio opacity that obliterates the left border of the aortic knob. As I have already told you, this aortic knob is posterior, whereas ascending aorta is anterior. Therefore, ascending aorta border is, if it is obscured, means the pathology is anterior. If this is obscured, means the pathology is posterior. And radio opacity that obliterates the left border of the aortic knob, a posterior structure, lies in the apico-posterior segment of the left upper lobe, apico-posterior segment of the left upper lobe, or in the posterior mediastinum or the posterior pleural cavity. A shadow that overlaps but does not obliterate the aortic knob is anterior. If it is not obliterating but it is overlapping, means it is not in the posterior mediastinum. If it is not in the posterior, it will be in the anterior mediastinum. Okay. A shadow that overlaps but does not obliterate the aortic knob is anterior or far posterior and lies in the anterior segment of the left upper lobe, the superior segment of the left lower lobe, and in the anterior mediastinum or far posterior portion of the mediastinum or pleural cavity. Here in this radiograph, we can see the left lower lobe apical segment consolidation here without any obscuration of the left heart border. There is no obscuration of the left heart border or the aortic knob. And the Silhouette sign is applied to the right border of the trachea, but this is unreliable because in many normal individuals, the right tracheal border cannot be seen even on adequately penetrated films, and the same is true for the cephalic aspect of the aortic knob. And now coming to the salient points. Here we can see in these radiographs, this is the right middle lobe consolidation. This is one of the entrance bit. Mostly they will be giving this one. In right middle lobe consolidation, the right heart border is obscured and Silhouette sign is present. And right lower lobe consolidation means the border is preserved. Therefore, it is in the lower lobe. And here the lingular consolidation, here the left heart border is obscured, and the left lower lobe consolidation, here the border is preserved. An appropriately located lesion in the anterior segment of the upper lobe shows the Silhouette sign on the heart or ascending aorta, whereas a posterior segment lesion does not. An anterior mediastinal mass causes a Silhouette sign on the heart or ascending aorta, but a posterior one does not, although it may obliterate the aortic knob. Posterior encapsulation of pleural fluid does not produce the Silhouette sign on the heart or ascending aorta, but anterior medial encapsulation of the free pleural effusion does. And now coming to the summary, the Silhouette sign, it is the loss of contour of left heart border, means left heart border. This is the nutshell of the whole presentation. Here, the left heart, if the left heart border is obscured, means there is lingular disease and hemidiaphragm. We have discussed about the borders of the between the lung and the heart. What happens if the border of the diaphragm is obscured? Means the pathology will be in the lower lobe. So, since the lower lobe is in contact with the diaphragm, hemidiaphragm is obscured, means lower lobe lung disease, and paratracheal stripe is obscured. Paratracheal stripe is nothing but the here the trachea is aerated, therefore it will be radiolucent, and the adjacent lung is also radiolucent, and between this trachea and the lung there is a fine strip. It is about 5 mm, nearly 5 mm thickness, and this is the paratracheal stripe. If this paratracheal stripe is obscured, means there is a paratracheal disease. And the chest wall, like lung pleural or rib disease, and aortic knuckle, means aortic knob. The pathology is in the anterior mediastinum or the left upper lobe disease. And if the paraspinal lines are obscured, means this is the posterior thorax disease. And if the right heart border is obscured, means the middle lobe disease. It is in the middle lobe. Thank you.
ఈయన వచ్చే మనోడు ఏమన్నారు